Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. Today, I would like to discuss with you the best contraceptive method used for PCOS patients. The first question, should we prescribe contraception for all patients of PCOS? This is an important issue because we can prescribe contraception for avoiding pregnancy for those who have sufficient number of children or do not desire to have babies. And we can prescribe contraception as a treatment of PCOS. But we should consider that infertile patients with PCOS should not be treated by contraception rather than they should be treated by metformin and induction of ovulation. Before discussion of the best contraception used for PCOS patients, we have to understand that PCOS is a reproductive cardiometabolic syndrome with many or multiple comorbidities, and it is caused by multi factors. So it is mainly affected by the change in the circulation due to insulin resistance and hyperinsulinemia. And insulin resistance leads to metabolic abnormalities due to affection of the three important insulin dependent organs, which are adipose tissue, skeletal muscles, and liver. The ultimate result of this is excessive androgen production, as insulin is one of the causes of the hyperandrogenemia. Moreover, hyperandrogenemia will lead to hyperinsulinemia. So this is a vicious circle at one side. The other side, there is endocrinal problem that leads to reproductive abnormalities in the form of increased GnRH hormone, increased ACTH, increased LH, and increased insulin also stimulates androgens from the theca cells of the ovaries that lead to BCO morphology by ultrasound, increased anti-Mullerian hormone, and other hormonal imbalance. In addition, excessive estrogen will lead to endometrial hyperplasia. So these are alterations of the insulin signaling that has been recognized as the main cause of PCOS. So PCOS is not only an ovarian abnormality or morphological problem of the ovary by ultrasound, rather than being a systemic disease. And if you look to this patient, you will find that PCOS will affect the whole body, starting by hair loss, starting by hair growth in abnormal areas, which is hirsutism on the lips, on the chest, on the back, and on the abdomen, psychological problems, cardiovascular problems, acne, excessive weight gain, which is apple appearance, which means excessive waist circumference, which is against peer appearance, which is the fat adiposition or deposition around the hips, buttocks, and thigh. And waist to hip ratio will increase more than 0.8 in the females, and it's more risky than general obesity or increased body mass index. Also in the ovary, you will see BCO morphology, some ovarian cysts, infertility, misperiods, and some skin pigmentations. So in addition to insulin resistance, which is a common finding in PCOS patients. We have to consider that PCOS is a risk factor for venous thromboembolism. It increases the risk by the odds ratio or relative risk is 1.7, which the normal relative risk or odds ratio should be 1 or less. Here it is 1.7 in some studies, which means that PCOS is a risk factor for VTE. So if we put these findings or these basics in mind, when we are selecting a method of contraception for PCOS patients, we have to consider combined hormonal contraception, which means estrogen plus progesterone, as one of the best methods for contraceptive use in PCOS, particularly COCs. COCs contain progesterone, which is progestin. Synthetic progesterone inhibits ovulation by inhibiting LH release, in addition to prevention of timed fertilization by inhibiting fallopian tube peristalsis and some cervical mucus changes. In addition, estrogen component contributes to better bleeding control and inhibits FSH release and stabilizing the endometrium. And importantly to know that estrogen increases sex hormone binding globulin release from the liver, and this leads to decreased hyperandrogenemia. So COCs are considered one of the best methods of contraceptive use during PCOS because of the contraceptive efficacy, high efficacy, and non-contraceptive benefits all of us know. But the non-contraceptive benefits in PCOS are more than other females or other population, because it leads to improvement of menstrual irregularities, improvement of the cosmetic appearance, which disfiguring acne, disfiguring hirsutism, and hair loss. So it has aesthetic improvement, which is an advantage of using COCs in PCOS. Also, it is important for treating hyperandrogenism. And we have to consider this point in mind, that if we will give COCs to the PCOS patients, even young age, this is a treatment of the case, not to use it as a contraception. It is a treatment of hyperandrogenemia and some cosmetic problems of hirsutism and acne, and in addition to alopecia. And by giving those patients COCs, the long-term effect of the PCOS, like insulin resistance and cardiometabolic problems, would be alleviated. And this is important to mitigate these problems. Importantly, also to know that the COCs have important anti-androgenic functions. The estrogen, as I told you, increases sense of sex hormone binding globulin in the liver, which leads to decreased free testosterone in the circulation. Regarding the progestogen or progestogen component of COCs, it leads to suppression of LH to achieve anovulation, and this leads to decreased androgen at the same time. Some of the types of progestins or progestogens may have effect on androgen receptor as androgen receptor antagonist and 5-alpha reductase enzyme suppression, which is an important enzyme to change testosterone into dihydrotestosterone, which is the active form of testosterone. And this effect is variable according to the dose and according to the type. So if we look to this table, you will find cyproterone acetate, which is a first generation progestin described in 1961. Cyproterone acetate plus some anti-androgenic medications like flutamide, they have effect of androgen receptor by being androgen receptor antagonist, and also decreases LH, as I told you, for induction of anovulation, decrease ovarian androgen production. But the spironolactone, which is derivatives which are trospirinone, also has androgen receptor antagonist effect, but inhibits 5-alpha reductase enzyme effect in the skin to minimize the effect, a change of testosterone into the active dihydrotestosterone. So spironolactone-like and finasteride are examples of this mechanism of action. So both types can inhibit androgen receptors in addition to extra effects. And some studies found that the anti-androgenic effect of COCs is superior to using anti-androgenic medications. And the recommendation of many societies that anti-androgenic medications used for treating hirsutism and PCOS should be given only if the COCs are contraindicated, poorly tolerated, or suboptimal response after a minimal 6 months of use. And this is because the support that the anti-androgens are not superior to COCs in hyperandrogenemia in PCOS. In addition, COCs are important to protect the endometrium by ensuring regular monthly shedding with the endometrium and avoiding endometrial hyperplasia and endometrial carcinoma. So the recommendations of the society is that for adults with PCOS, we have to prescribe COCs to treat menstrual abnormalities, hirsutism, acne, and hair loss, which are hyperandrogenemia, metabolic, and hormonal dysfunction. Also for adolescents, they should be given this line of therapy as a management of such conditions, those adolescents who are at risk or with clear diagnosis. Also, the recommendations again that the COCs are first-line treatment of menstrual irregularities, acne, and hirsutism in women with PCOS. There is insufficient information to define the optimal duration of treatment, and the same applies that it is the first line of treatment in adolescents requirement treatment of acne, hirsutism, menstrual disturbances. But before giving COCs to any patient, you are not a pharmacist. You should evaluate the patient regarding the lifestyle modifications. The patient should be advised to have lifestyle modification, diet and exercise. You have to exclude metabolic problems, cardiac problems. You have to use the stethoscope to hear the heart, to measure the blood pressure, to estimate body mass index, waist, hip circumference ratio, assess hirsutism by hirsutism risk, blood sugar measurement, GTT 75 grams, oral GTT test, fasting lipid profile, liver functions, and beta HCG, of course, to exclude pregnancy because those patients have periods of amenorrhea all the time. So consider the cardiometabolic profile before prescribing COCs. This is an important step before giving the patient COCs. This is a serious drug. And why it is serious in PCOS, you will see now. So you have to exclude contraindications of COCs like age, increased age, which increases arterial problems, or smoking, obesity, glucose intolerance, alcohol drinking, hypertension, dyslipidemia, thrombophilia, and family history of VTE. Now I decided to give the patient COCs for hirsutism, for acne, for menstrual irregularities, whether she is desiring to stop pregnancy or not. Which type should I use? Actually, if you go to the recommendations, you will find no first line oral contraceptive pills to be used in those cases. There is second line, which is a combination of ethinyl estradiol and cyprotrone acetate, which is 2 milligrams cyprotrone acetate. As I told you, it is first generation progesterone or progestogen, in addition to 35 micro of ethinyl estradiol. Why there is no first line? Because as also recommendations that cyprotrone acetate is second line, as I told you, because it has been found that despite the beneficial effects of cyprotrone acetate ethinyl estradiol combination, which is DIAN, decreasing body mass index, decreasing hirsutism, decrease free androgen index, decrease total testosterone compared to other methods of contraception. Despite these advantages, it is not recommended as a first-line treatment because of the high incidence of VTE with the use of cyprotrone acetate. And of course, VTE is important in females because females are liable to VTE more than other populations, and male or children or And the incidence is 5 to 10 events in 10,000 women a year in general population. And the increase of VTE in females by using hormones, particularly COCs, is higher, and it's more or less increasing with different types of the hormones inside the COCs. And the relative risk in all kinds of COCs user is 3.5. It should be 1 or less. And of course, in pregnancy, it's much more, 1.2 per 10,000 deliveries. And in some women using postmenopausal hormonal treatment, and in IVF patients and some older age, increase the risk. We have to know that COCs or patches increase the risk of VTE 8 times more than non-users, and vaginal rings increase the risk by 6.5 times more than non-users. Progesterone or progestogen-only pills have no increased risk of VTE, and HRT increases the risk twice. And this has been recently published in some publications. If we go to the types of progestogen in the COCs, you will find that the risk regarding VTE using levonorgestrel is 1, which is excellent, which means no association between the use of levonorgestrel and COCs. That's why progesterone-only pills have no risk. And the Norge estimate 1.14, which is again a good percentage. And the risk of VTE with these two types is half the risk with other types of progestogens like desogestrel, gestodine, and drospirenone as well. In addition to cyproterone acetate is 2. The risk is 2, which is much more higher than other types of progestins. And dinogest also is 1.46. So if we summarize these cardiovascular risks with COC, we will find VTE, which is venous, and arterial, which is MI and stroke. The VTE diminishes over time with the COC use, which means that if the patient is using COCs for a long time, the risk of VTE decreases. And actually, it is associated, the VTE effect is related to estrogen component and progesterone component, estrogen dose and progesterone type. So the higher the dose of estrogen, the higher the risk of VTE. Here is 35, is the relative risk is 1.9 to 2.2 in some studies, and the relative risk of using 20 microgram, like that's in years, for example, this relative risk is 0.8, which is no association. So the estrogen type is important. On the other hand, estrogen dose is important. On the other hand, progesterone type, as I already mentioned, the cyproterone acetate is 2.04, which is the highest risk of VTE. That's why it is not, despite being an excellent anti-androgenic product, it is not recommended as a first line because of the higher VTE risk is of a relative risk of 2. If we look to the arterial risks of COCs, you will find MI and stroke, and this arterial risk actually is less than VTE in this young age women who are using the contraceptive methods, but the effect on the arteries is related to increased estrogen dose, and the progestin type has no impact on arterial complications, and the arterial risk increases with time. The VTE decreases with time. This increases with time due to increased risk of age, which is 2 per 10,000 per year, due to increased age of the female. And this is the difference between VTE and arterial complications. So don't forget that cyproterone acetate here in this publication is found, it's put as 4th generation. Actually, it is 1st generation, and it has excellent anti-androgenic activity among all progestins. The best of anti-androgenic drug, but it is not the best, it is not the first, because of the risk of the VTE, as I already mentioned. Drospirenone has anti-androgenic effect. In addition, it has anti-hypertension effect, actually due to decrease in mineralocorticoids, and this is an advantage of drospirenone, which is spironolactone-like. Other first generation, second generation are also not recommended because they don't have anti-androgenic effect. So in PCOS, we are searching for a contraception which has dual effect: contraception, control of menstrual irregularities, and anti-androgenic effect, because those patients have hyperandrogenemia, as I told you, secondary to hyperinsulinemia and insulin resistance. So what's the solution to have a good effect, anti-androgenic effect, and at the same time to decrease the risk of VTE? If we look to the progesterone component of DIAN, which is ciproterone acetate, the solution is to change this method, to use to use less serious generations of progestogen like drospirenone and dionagest, which are promising regarding decreased risk of VTE. And as I told you, drospirenone is spironolactone derivative. Ciproterone acetate is 17 progesterone derivative, and dionagest is testosterone derivative. So we can shift to dionagest or drospirenone and stop using the ciproterone acetate due to the increased risk of VTE. But again, the quality of life is improving with using ciproterone acetate if it is compared to the first generation levonorgestrel, which has relative risk of 1 regarding VTE, but the quality of life is much more better with ciproterone acetate, as I told you, because it has excellent anti-androgenic COCs. So spironolactone is drospirenone. This spironolactone derivative is drospirenone, has anti-mineralocorticoid, and this is an extra advantage of using drospirenone instead of ciproterone acetate, as it decreases blood pressure. So it's good for patients with borderline blood pressure or liable to hypertension as well. And this is advantageous over using the dionagest. Drospirenone 3 milligram plus 20 micro is yes, 30 micro is Yasmin. But dionagest also has good effect regarding the acne and hyperandrogenism, but it is associated with higher risk of venous thromboembolism, 1.146, if it is compared to drospirenone, the same risk as well. And instead we can change the dose of ethinyl estradiol. You mentioned that the risk of VTE is related to the dose of estrogen or the type of progesterone. So we can use lower dose of ethinyl estradiol. Particularly, there is no improvement in hirsutism and hyperandrogenemia if we increase the dose of ethinyl estradiol. So it seems logical that we use lower ethinyl estradiol dose, and this is another solution approach, and this is an interesting option, should be considered in the future. So we can replace ethinyl estradiol by natural estrogens like estradiol or estradiol valerate, and more recently estetrol, which has been started to be in the markets in 2021. And of course, the bioavailability of ethinyl estradiol is much more higher. That's why we are using smaller dose, micrograms, but the bioavailability of estradiol valerate is less, and estetrol is much more less. But you have to consider that these alternative estrogens have the advantages of decreased blood pressure at the same time. It's found in this study, in addition to spironolactone and derivative, which is drospirenone. If we look to the most recent natural estrogen, which is estetrol, which is estrogen 4, actually it is formed by the fetal liver in utero and now commercially synthesized from soybean. If we give the dose of 14.2 milligram of estetrol plus 3 micromilligram of drospirenone, this will lead to lower risk of VTE than ethinyl estradiol COCs. And if we look to the breast, it's more advantageous than other types of estrogen because it has no stimulatory effect on the membrane estrogen receptor alpha, which is stimulating proliferation of the breast tissue, which is one of the risk factors of developing breast cancer. So the advantages of estradiol that it inhibits breast proliferation, it has minimal effect on the liver, decreased thrombogenic potential, and actually in the vascular system, it leads to increased nitric oxide production and decreases blood pressure. So it is advantageous, decreasing blood pressure like drospirenone. If we combine it with drospirenone, which also has antihypertensive effect. So this would be an excellent option. And nowadays it's under trials, it's actually found in the markets. Drospirenone 3 milligram plus estradiol 14.2 milligram plus 4 tablets placebo. As I told you, the bioavailability of ethinyl estradiol is much more higher than others. That's why we are using micrograms, and estradiol valerate is 2 to 3 milligram. Estradiol is 14 milligram because the bioavailability of estradiol is 100 times less than the estradiol valerate, which is less than ethinyl estradiol. That's why most of the COCs are using ethinyl estradiol due to the high bioavailability. Lastly, you have to consider that some patients who are PCOS, if you give them COCs, they will come. No, sorry. Some patients who are using COCs, after stoppage of COCs, they come with periods of amenorrhea, acne, hirsutism, and these are surprised why I have acne, hirsutism. I don't have PCOS before. And you find by ultrasound PCO morphology in those cases, and this is called post-pill PCOS. And actually, it is a temporary condition, so you have to assure your patients and optimize nutrition, restore micronutrients, support liver and gut health for microbiota, and consider supplementation to improve the general condition. But generally, it is a temporary condition, which is post-pill PCO finding. And actually, it is one of the types of PCOS, which is insulin resistant, as I already mentioned, pill-induced PCOS, and inflammatory PCOS. Again, another point, if the patient is becoming older, 50 years or more, you have to switch from COCs to progestin only, particularly levonorgestrel IUD system or IU system, implants or POP, rather than giving them COCs. And of course, the Depo-Provera or depo-medroxyprogesterone acetate is not recommended in this age group due to higher risk of breast cancer. So this is enough for the COCs and the choice of the first one, and how to overcome the problem of cyproterone acetate by changing the estrogen dose and the progestin type, as I mentioned. Other types of combined hormonal contraception include transdermal patches and rings. Actually, what's mentioned regarding the risks of COCs is similar or applied to the rings and patches because they are combined estrogen progesterone. Regardless the type of progesterone, regardless ethinyl estradiol, the type of progesterone differs. We have one-time use ring, which is enough for one time for one cycle, 3 weeks use, 1 week off, but it is valid for 5 weeks. Actually, it contains etonogestrel, but there is 1 year use, which is another type of progesterone, sigstostrone acetate, in addition to ethinyl estradiol, and it is used 3 weeks, use 1 week off for 1 year, and this is reused again. And they are contraindicated again in patients with risk of venous or arterial thrombotic problems, breast cancer, and severe liver problem. They do not appear to be safer than COCs regarding the metabolic effects, and they are similar to COCs. It depends upon the patient's convenience, actually, and the batches also contain estrogen, ethinyl estradiol, and progesterone, norelistramine, And actually, there are different types of patches. Again, 3 weeks, 1 week off. And they have 8 times greater risk of VTE than non-users of COCs or patches. So this is about combined hormonal contraception, estrogen plus progesterone, and the risks regarding their use in COC and PCOS patients who already are at risk to develop VTE 1.7 odds ratio. Okay, we will use progestin-only contraception actually to minimize risks of estrogen dose or estrogen type for VTE and for breast cancer development. So we can give POP, we can give levonorgestrel IUD, we can give implanon or nexplanon or dipomedroxyprogesterone acetate. Here are the different types of progestin-only contraceptives, and you can go back to the lecture of the hysteroscopy for progestin-only contraceptives with more discussion. And again, progestin-only contraceptives are considered for endometrial protection in patients who are liable to endometrial hyperplasia or endometrial carcinoma. We have to consider these progestin-only contraceptives, and those patients who is contraindication to estrogen due to cardiometabolic problems, cardiovascular problems, the intolerance, and other contraindications, we can prescribe to them progestin only, particularly POP, which has no risk of VTE, and we can give intrauterine levonorgestrel, we can give implanon, nexplanon, but regarding injection, the risks outweigh the benefits. So you have to avoid medroxyprogesterone acetate as much as you can. And the implanon and nexplanon are used, and the nexplanon is more radiopaque, so it can be detected by X-ray if it is missed and we cannot find it, with release of etonogestrel 68 milligram containing release every day 25 to 30 microgram for 3 years. Also, we have to consider POP, and one of the advantages or one of the recent POP in the market, which is FDA approved, is drospirenone 4 milligram. So this drospirenone 4 milligram is used for 24 days and 4 days with supplement or iron, and it has good inhibitory effect on the ovulation, good tolerability, good cycle control, and less risk. So the progestin-only pill has no risk of VTE, and this is another advantage. And the use of mini pill in PCOS seems not to affect cardiometabolic parameters in healthy women. What about intrauterine device? The copper IUD or other types of IUD, non-hormonal IUD, are not advantageous in patients with PCOS because, as I told you, they are liable to endometrial thickening, endometrial hyperplasia. So if we put a foreign body inside, this can stimulate more hyperplasia or more proliferation of the endometrium. So if you put intrauterine device, it should be hormonal levonorgestrel release of progesterone that leads to thinning of the endometrium as anti-inflammatory, anti-proliferative effect. And it's advantageous over using oral progestin in reversing endometrial thickening in hyperplasia in those patients. But unlike COCs, patches, and rings, the IUD is ineffective for treatment acne and hirsutism or hyperandrogenemia. So its effect is in the endometrium. So if you select intrauterine device containing hormone, it's for menstrual control and for treatment of thick endometrium, not for systemic manifestation. Regarding dipomedroxyprogesterone acetate is not recommended despite lack of data regarding its use in PCOS. It's not recommended because higher risk of stimulation or proliferation of breast tissue and also risk of venous thromboembolism 2.2, more than 2, and breast cancer 2.2, as I already mentioned. with unfavorable cardiometabolic parameters than progesterone only. Implanon and nexplanon, I already mentioned to you these advantages. So these are the methods of contraception used for contraception and for other advantages like cycle control, like treatment of hyperandrogenemia. So what are the conclusions? Since PCOS is a risk factor for venous thromboembolism, screening of women with PCOS for cardiometabolic and psychologic or psychiatric comorbidities is routinely recommended. And PCOS is a risk of cardiometabolic problems, and transvaginal sonography is mandatory before prescribing the COCs or other methods. You have to do transvaginal ultrasound to check endometrial thickening. If you find endometrial thickness, you have to give a method of contraception that inhibits endometrial thickening after exclusion of possibility of endometrial hyperplasia or endometrial carcinoma. And this is the best method will be shown now. There is no best contraception for PCOS patients because of the risks associated with use of COCs, particularly cyproterone acetate containing COCs. So the best contraception for PCOS can differ from one person to another according to the clinical situation. Here I summarize to the clinical situation. In addition to improvement of the lifestyle of the patient, diet, exercise, if the patient comes with irregular periods, okay, COCs, patches or rings, and give them also metformin as they are PCO patients for insulin resistance. If they have overweight, metabolic effects, insulin resistance, okay, metformin is good, in addition to these methods of contraception as well, because COCs are also improve insulin resistance. Also, you can give them anti-obesity drugs or inositol. If they have hyperandrogenism, including acne, hirsutism, alopecia, or hair loss, you can give them the best hyperandrogenic drug, which is cyproterone acetate, drospirenone containing COCs, patches, or rings. If the patient has thick endometrium or endometrial hyperplasia, levonorgestrel intrauterine system. For endometrial protection, BCO, you can give her progesterone-only contraceptives, POP or LARC, okay? For hypertension, if the patient is borderline hypertension or has history of hypertension, you should give her a method that does not increase blood pressure, as I told you, drospirenone containing COCs or a natural estrogen or estetrol. There is combination of estetrol and drospirenone, as I told you, 3 milligram drospirenone and 12.4 milligram estetrol. If the patient is infertile, don't give her PCO, give her contraception. You should give her metformin, lifestyle modification, and induction of ovulation. By this way, we can stratify the methods of contraception, and we understand the actual role of contraception in PCOS patients. Thank you.